Greetings, everybody. My name is Sham Saeed, and it's a real privilege to be able to warmly welcome each of you to this Global Health Compassion Rounds, which is jointly hosted by the Focus Area for Compassion and Ethics at the Task Force for Global Health and the WHO Global Learning Laboratory for Quality. As with each of these Global Health Compassion Rounds, we have an opportunity today to delve into a specific area of focus and explore the important linkages with compassion. Today, the subject is the movement to eliminate neglected tropical diseases. Our intention, as always, is to share our thinking, to challenge each other, and hopefully spark new thinking on a subject matter which is incredibly important for populations across the world. Just to remind ourselves that that openness is focused on a mutual respect for each other's thoughts, and also to remind ourselves of the compass that we often talk about when it comes to compassion. The compassion equation that we often refer to in terms of awareness, empathy, and action. And this is something that the Task Force for Global Health and FACE in particular has highlighted for a number of years. We should also emphasize that with any subject matter comes controversies, and we embrace those controversies as part of the spirit of these Global Health Compassion Rounds. We also recognize the important linkages between the discourse and the delivery of quality health care and quality health services for populations across the world. So we have a depth within this panel today that is hard to meet or challenge. But our task today is to challenge each other and to make sure that we stretch ourselves beyond our initial thoughts. So our criteria of success is somehow that by the end of this webinar or this Global Health Compassion Round, we will come out of it slightly different to how we entered it. And with that, if I may, I'll turn to David Addis, who has been instrumental in developing these Global Health Compassion Rounds. David.
Thank you very much, Shams, and it's such a pleasure to be here with you and with our esteemed panelists today. I'd like to say a few words about neglected tropical diseases for our audience who may not be familiar with that term or understand the really impressive programming that has developed over the last few years. This will be old news to many of colleagues on the webinar who are in the NTD field. But initially, after many years of trying to get traction and funding and interest in these diseases of neglected people, really, in the early 2000s, a group of enterprising people led by WHO said, can we bundle these diseases together? And what happens to the burden of disease compared to the big three, HIV, malaria, tuberculosis, if we do so? And of the 17 diseases that were considered at the time, clearly the burden measured by disability adjusted life years was greater than that for malaria and tuberculosis, suggesting that coming together would actually help in promoting control and elimination of these diseases. NTDs are really diseases of neglected people. They tend to overlap in the same area. The map that you're seeing on this slide shows the map of 6 common NTDs. And you can see that in many areas, all 5 or 6 of these diseases are present in the same country. So these are markers of poverty, They affect health, education, development, gender equity, and there's a vicious cycle between poor health and poor development that has been really persistent in many of these areas. So the initial strategies to address neglected tropical diseases unabashedly proclaim themselves as pro-poor. This was not just about alleviating disease or the suffering of disease, but actually promoting development, promoting well-being, particularly for those who were least resourced economically and who were affected by these diseases. This is the list of the current 20 neglected tropical diseases. Many of them may be unpronounceable to many of you. They are diseases that occur largely, but not exclusively, in tropical areas. And most of them had received limited attention before being bundled together under the NTD rubric. Now, there are several strategies, as you might imagine, for addressing these diseases since they're so diverse. I'd like to highlight two of the major ones: preventive chemotherapy, which is, or mass drug administration, which is the delivery of single doses of medication periodically, usually once every 6 months or once a year, to reduce transmission and to alleviate disease. And there are currently 5 diseases that are primarily addressed through mass drug administration or preventive chemotherapy now. Another major group involves intensified disease management, bringing the correct tools and diagnostic modalities to take care of these diseases within the context of primary health care. And then certainly vector control is very important for these. Water sanitation and hygiene is crucial, as is control of zoonotic diseases, many of which these diseases are zoonotic. So it's a rather multifaceted bundle of interventions that are used to address these 20 diseases. I'd like to turn briefly now to compassion. And as Shams mentioned, we look at compassion as a 3-part equation: awareness of suffering, the empathy or the emotional attunement to that awareness, and then action to relieve and prevent suffering. And I would argue, and maybe our panelists will too, that the NTD movement has actually been very much aligned with these 3 elements of compassion. In addition to the insights related to the physical suffering, the disease manifestations, from a very early on, investigators, scientists were aware of the stigma, the other realms of suffering that these diseases provoke. And so this has been part of the awareness of suffering going back years in the NTD movement, and front of mind for those who have been charged with trying to control or eliminate these diseases. There was an element of empathy in some of the early materials for the lymphatic filariasis movement, emotional attunement, and many people who worked in areas where these diseases occur also were very moved emotionally by the levels of suffering that these diseases occur. And then action, tremendous action, both on the clinical side, which we'll explore today, in mass drug administration, which now reaches 1 billion people worldwide, and then in the efforts to organize all of this, monitor, evaluate, as shown on the right side, with a team to certify the elimination of lymphatic filariasis in China. So I would argue that NTD movement has been aligned and organized really around the elements of compassion from the beginning. And with that, I'd like to turn it back to Shams. Thank you.
Thank you so much, David, for that very clear framing and context setting for our Global Health Compassion rounds today. I'd like to now call my colleague Jonathan King from WHO, who's the team lead for community and primary care-based interventions. And Jonathan will be speaking to reflect on what David has mentioned already. So just as a background, Jonathan comes, and I think many of you will know him well, but he's 20 plus years of experiences in NTDs, has been with WHO since 2014, and since 2020 has led the community and primary care-based interventions. And prior to that was working in the NTD space at the Carter Center and in the US CDC. Jonathan, your reflections on what has been said already and any further reflections that you'd like to provide, Jonathan.
Thanks a lot, Shams. And thanks, David, for setting the context. First, I know that many of you had seen that our director, Dr. Moyle Molichella, was going to speak, and unfortunately, she's not well. And it's very close to her heart, compassion, and she's a living example of compassion in her work and her leadership. And I fortunately get the opportunity to have this discussion with you all. And you know, one thing that I can say after having nearly all of my working career in neglected tropical diseases is that the community is filled with passionate and compassionate people from all walks of life, from all levels, from all stakeholders. And I believe that, and I've seen that it's been a tidal wave of compassion, of love and kindness poured out among the NTD community, not only to initiate these programs, but also to sustain them to where they are, to see the tremendous progress that's happened to date. And I think we're all on the same compassionate vision, a world free of suffering due to NTDs and communities not hindered by preventable diseases. These are preventable, avoidable diseases. Not one person should have to suffer due to lymphatic filariasis or trachoma or any other NTD. Just to share my own experience, there's a couple of questions that we have to ask ourselves. I think we should in life, and one is, what is the purpose of life? And the two is, what are we going to do with our life? So I don't know if I have all the answers to number one, but number two was really brought forward to me, and I think I was moved by compassion with my very first encounter with someone with lymphatic filariasis, a man affected with hydrocele. And in graduate school, I had just written a paper on LF, and then a few months later had this interaction and you know, felt empathy toward the gentleman's situation. And from, you know, in the current setting where I was with my interaction, I could not provide help for that person. But I knew that this was lymphatic filariasis, and I knew that this is an avoidable condition, and I can do something about this. And I believe that experience shaped my working career. Every time I have the action to or interaction with persons affected by NTDs, it's a blessing for me to be around, and it strengthens my own personal commitment and reason for working in NTDs. But I think, you know, this is common among the community, and you know, with the help of the NTD community recently, you're all aware of the NTD roadmap, and several of you contributed to this and had input. And these are to setting the global targets for control and elimination of NTDs up to 2030. So not only does it have the targets, but it really, I think, is a blueprint for compassion in action, or way to express our compassion is carrying out this document, the goals in this document. And we're definitely at WHO grateful for the community and all the commitment that's put into making the goals of the roadmap come to realization. There are certain themes in the roadmap that I think bring out compassion as well. Obviously, disability management and disability inclusion, and that focus in patient-centered or person-centered care. This, for the lymphatic filariasis program, the desire to the awareness and the desire to do something about the suffering of the disease, I believe, was the main motivating factor for countries and stakeholders and the commitment to the World Health Assembly resolution for eliminating lymphatic filariasis. And it's also this commitment that's kept disease management and disability management as one of the global program to eliminate lymphatic filariasis core aims. I think there's other cross-cutting things as well. I mean, the incorporation of safety. David mentioned about 1 billion people that we provide preventive chemotherapy through the treatment to interrupt transmission of NTDs, but a special attention to try to ensure that no harm is done through this process. Something that may not be the first thing that you would think of, but capacity building and a shift, a core theme of the roadmap, the shift to country ownership. I think in the initiation of the NTD community, there has been a sense of partner-led activities or partner-led priorities. And I believe that if we can work to shift to country-led decisions for stakeholders and external partners to listen and to be attuned to the needs of countries who are working and investing their time to avoid suffering and eliminate these NTDs. So, I mean, in closing, I just would share the commitment of WHO, and I think that this roadmap provides a way for us to express the compassion in NTDs and to bring in new commitments and financial commitments too from stakeholders. Now is a better time to demonstrate commitment to this cause, and through that reflecting the compassion that we feel and what drives us to want to eliminate these diseases.
Thank you very much, Jonathan, for those thoughts, and also very much appreciate the personal piece that you brought into this in terms of some of the questions that you posed to yourself and how that also morphed into some thinking related to strategic level, global level roadmaps. But of course, it reminds us that ultimately individual interactions count, and so they count significantly in each of our lives. So now we will transition into the panel to be able to get through some of the global expertise that we have from various continents and in various subject areas. We have a depth of expertise that we'd have to get through and have the privilege to listen to. So perhaps with that, I pass to David to take us through the panel, but just to encourage colleagues to ask any questions as you listen to the panel in the Q&A, which we will then utilize for the Q&A session. David.
Thank you very much, Shams. It's really a pleasure to introduce this spectacular panel that we have to reflect on compassion in its various manifestations within the NTD movement in global health. We have presentations from the sort of multilateral perspective, the government perspective, NGOs, clinical care, as well as persons affected. And so we really look forward to a rich discussion. I'd like to invite first Professor Uche Amazigo, who many of you know. She was the former director of the African Program for Onchocerciasis Control, APOC. And Uche was really a fierce defendant and advocate for community drug distributors and communities affected by these diseases. She's her leadership in the area of mobilizing communities, the whole era of community-directed treatment, which now is being used in many other areas of global health, has really been phenomenal. And as many of you who know her know that she's an inspiring speaker and really speaks to the heart. So Dr. Amazigo, I'd love for you to share with us your thoughts on compassion, particularly in the realm of programs, large programs like APOC that you directed for several years. Thank you.
Thank you, David. The network is not quite stable here. I will try and see if I can share my screen from here. I'm going to continue with Sham's, Sham, thank you for that brilliant introduction, and David as well, and Jonathan. It's all on compassion, and I think that the neglected tropical diseases, all of them, really present compassion in a very clear manner. So I will take compassion in the delivery of healthcare, and I will use onchocerciasis and then perhaps the drug distributors that David talked about, because for me, they are really the foot soldiers, the army for healthcare delivery in sub-Saharan Africa. First, let me explain river blindness or onchocerciasis. It's a leading cause of visual impairment and skin disease as well. You can see from the pictures, the skin disease on this young girl can lead to disfigurement, to unrelenting itching, to social stigma, both in men and women, but really affects the girls, the young women more. Next slide. And I'm introducing you to the recent book of Bruce Benton, River Blindness in Africa, Taming the Lion's Stare. Please, if you have time, go read that book. It has everything you need to know about compassion in healthcare delivery and about river blindness and fighting river blindness in sub-Saharan Africa. So one of the fight against one of the world's most devastating neglected tropical diseases, devastating also economically, is the fight that received a global response from 1987. And that the foundation of that global response, as far as I know, is compassion. And so let us look at some of the slides, some of the points that I have raised in the next slide, following slide. Please, Hector. Now, the creation of the onchocerciasis control program in Africa, in West Africa, which you can find in Bruce's book as well, that the creation by the World Bank, which is the agency that took the first step, is based on compassion. And the initial report of the World Bank staff linked clearly health and development. And it's because of the compassion, if you read Bruce's book, the compassion in those individuals that led them to demonstrate the clear link between health and development. And then that was followed in 1972 by the trip of the World Bank president and his wife to Upper Volta. And during that trip, they visited villages along the Black Volta River and saw so many blind people, and many of them being led by young boys, which means those boys could no longer go to school. They did not go to Bobo de Lasso, ladies and gentlemen, for onchocerciasis. No, they went there to look at the impact of severe drought on the region. But when they got there, then they were taken by one of the French scientists to the villages along the Black Volta River, and that's where they saw so many blind people. And on the spot, President McNamara decided that he was going to create a group, bring a group together that will fight river blindness. That led to the launching of River Blindness Control Program, the OCP, in West Africa, and that covered 11 countries in West Africa. Their activities then was to kill the black flies and liberate people from the bite of the black flies, and that's the aerial larvicidin. There are so many stories. If you read the reports of the OCP, on compassion, the compassion the community leaders had, the community people, the compassion of the pilots who were doing the aerial larvicidin, the compassion of the scientists who would spend nights and nights in the field collecting flies, dissecting them, and trying to determine the best larvicide to apply at each season. Next slide, please. We also had then the launching, the donation of Mectizan. I am certain that many of you know the decision or the process that led to the unprecedented donation of Mectizan by Merck and Co. How Roy Vaglos announced that Mectizan is free, will be free for as long as is needed and for those who need it. That's a clear demonstration of compassion for the poor. Now, the next thing that happened within that period after launching, after the donation, was the onchocercical skin disease study in 1990. And that led to the story of Agnes and myself. I was fortunate also in trying to visit communities, to talk to women, on nutrition and health. I met this 19-year-old girl, Agnes. And I would say out of compassion, I started paying for her treatment. I reported the whole thing back to WHO Geneva, and that led to the 1990 pioneering study on onchocerciasis skin disease. Again, this is compassion. Now, next slide. The OCP study led to the OCP activities and successful activities led to the creation of APOC, plus the study on Agnes, because Agnes then became the face of APOC. So prominent was, compassion was the prominent force throughout the existence of APOC. And there are 5 contributing forces, I would say, that all had compassion. One, I had already mentioned the breadth and length of MEC's donation for as long as is needed. Then the story of Agnes with debilitating skin lesions. Now the NGDOs that joined APOC were already working on river blindness prevention programs. And so they were coming in contact quite often with blinding cases. They saw the devastating effect of blindness. And you can imagine that many of those NGDOs, and some of them still working today, had compassion for the blind and wanted to find solution. Now, the OCP management and scientists showed a lot of compassion. For me, that was another force. Then the leadership of TDR, Toro Godal. Toro Godal was already working for leprosy and was a very well-known figure and very emotional about leprosy cases. So you can see that he's funding the research on onchocerciasis skin disease was more or less a follow-up from his compassion on leprosy, leprosy patients, and the fact that he wanted an elimination of leprosy. Next slide. Now, you also find that when EPOC was formed, we had the technical consultative committee. There were 7 men. I wish one could write a report on those 7 technical consultative committee scientists. Very fine scientists like Professor Molyneux, that is David Molyneux. You had Professor, the Carter Center, Hopkins, he was there, quite a number of them, you know, and they sat for hours and hours trying to figure out how to bring the drugs to the communities. The drug is available, but how do you deliver these drugs to the communities, and where are the communities? And then the TDR stepped in with the Operational Research Task Force led by Professor Kale. And this task force, because I was also fortunate to be part of it, I remember hours when I would be sleeping myself and the gentlemen would keep on working and trying to find a solution to the problems of the poor. So if I want to skip that and skip everything, I like to zero in now for a few minutes on the drug distributors of NTDs. I have listed here only a few, really a few of what the drug distributors go through to bring drugs, NTD drugs, to their colleagues, to community members, year in, year out. Let's take example of Kaduna State. In the publication that was released this year by PLOS NTD, we found that in Kaduna State, in the 23 local government areas of Kaduna State, over 1,500 CDDs have served for more than 10 years. That is distributing NTD drugs. They started with ivermectin, then added albendazole. Now they're adding the other drugs, azithromycin, and they have served their communities for more than 10 years. And half of them for even 18 years, without any remuneration. One cannot go more. I don't see any other way of describing compassion for your community members, if not by providing services, making sure that they swallow these drugs every year in order to free them from neglected tropical diseases. Ghana has even a more impressive result. Over 9,000 CDDs, including females, have served more than their communities for more than 10 years, and 1/3 of them have served for 18 years in the 9 regions that where the Ghana Control Program is distributing NTD drugs. So overall, you'll find that CDDs, the community drug distributors, receive about 1/10 of the total value of opportunity costs they incur. But do they mind? No, they have compassion. They want a relief for their communities, for their community members. And so my last slide, the next one, I will then talk about the distances CDDs trek. I took one extreme case in Liberia in a village where CDDs could only reach the village after 5 to 8 hours of trekking. And then CDDs on the whole, both from Tanzania, from Cameroon, from Nigeria, and Liberia, we tried to estimate the minimum number of days a CDD works in a year to distribute NTD medicines to community members. And the minimum is 14 days, the maximum is about 21 days. So you'll see, ladies and gentlemen, that the whole NTD world, both the NGDOs that are operating as partners, the donors themselves that are providing the funds, the ministries of health staff, the community members, they have formed a strong partnership to make sure that compassion becomes a thread that runs through all their actions. And so awareness of suffering is there, empathy is there, but they round it up and cover it up with day-to-day action, year-to-year action, some for 18 years, to make sure that they rid us from neglected tropical diseases. On that note, I want to stop here and wait for your questions. Thank you very much.
Thank you so much, Uche. That was brilliant. You really have convinced me, if there was any doubt, of the just crucial element of compassion in all of this action. Very, really elegant description of the thread of compassion through the entire APOC program and the ONCO program. So thank you very much. I'd like now to turn to Dr. Suma Krishnasastry, who is a professor of medicine and has been taking care, providing clinical care to people with lymphatic filariasis for many years. She's the head of the Filariasis Research Unit and the WHO Collaborating Center at the Government Medical College in Alappuzha, Kerala in India. I've known Dr. Suma for many years, and I'm really looking forward, Suma, to your presentation. Thank you.
Thank you, David. Thank you, Shams and Jonathan. Let me share my screen. I'm moving on to another neglected tropical disease, that is the lymphatic filariasis, and how the compassion is being practiced in lymphatic filariasis. The lymphatic filariasis, the very common in many parts of in 72 countries, and the chronic manifestations of lymphatic filariasis are the chronic lymphedema, then hydrocele, and the acute manifestation of acute lymphangitis. So the global program to eliminate lymphatic filariasis has two arms. The first one is to stop the transmission by giving the mass drug administration. And the second one is the alleviate suffering and improve quality of life of person affected with lymphatic filariasis. So that is otherwise known as morbidity management and disability prevention, or MMDP. And the lymphatic filariasis the MMDP has several components, like managing the lymphedema, treating the acute attacks, management of hydrocele, and treatment of remaining infection. All this forms the patient care. So I would like to say always that this is a neglected tropical disease, and in the lymphatic filariasis, the most neglected part is the patients. So how we can improve upon the patient care, and that is the question here. Now we have learned from, or we have heard from the previous speakers, the components of the compassion. So the compassion first component is that you have to be aware of the suffering of the person. And when you are aware of the suffering of the person, there should be an emotional resonance. That is what is called as empathy. It doesn't stop with empathy, but there should be a desire to action to alleviate the suffering. So there should be empathy plus action, then it becomes compassion. So look at a patient with lymphatic filariasis, either in the program or in the usual patient care. So there, the clinical management will be like, as I said, the lymphedema management or a treatment of acute attack or prevention of acute attack. But these patients, apart from their physical problems or the disease process, there are a lot of suffering, like the physical suffering, because when they have the lymphedema, they will not be able to move around as easily as anybody else. They will not be able to use the public transport system. And there may be that they may not get the adequate job because of the physical disability as well as the huge limb or the lymphedema. There will be a lot of psychological problems because this is a disease which has a lot of stigma. Previously, it is when in a family, if there is a person with lymphedema or hydrocele, they were not allowed to come to the front of the house when there are guests, or they were not allowed to go for the functions or such like that. So there was always a stigma was there, and this stigma and all that will produce psychological effect for the patients also. There is social exclusion was there, and there are many stories when you hear the patients talking about those things. I think then we'll know what are the extent of suffering these patients are having. And economic problems are also there, that they get recurrent episodes of fever. And when they get fever, they will not be able to go for the job. They'll have to be in bed for about 10 days or more than 10 days. So they suffer, there'll be economic loss and wage loss. And also that there'll be more disability at that stage also. So just by looking at the lymphedema alone, we can't say that, oh, this patient has only lymphedema, so you can just manage clinically the lymphedema and leave it. But there are a lot of suffering, and it is the primary responsibility of the healthcare provider to know about this suffering also. And that should lead on to the compassion also. So for a proper management and seeing the patient as a whole, as a person, what is required, clinical excellence as well as compassion. Clinical management should be properly done, and that is clinical excellence, because these should go hand in hand. You cannot say that you can just treat the patient and there is no emotional resonance or supporting the patient. And compassion alone also will not be enough for the management of the patient. So always it should be clinical excellence and compassion. So what does this compassion do to the patients? Or what are the perspective from the patient due to the compassion? So it has been, there have been large studies where the effects of compassion has been measured, and also there are studies where all these factors have been found out. And based on that, there are definite clinical effects when you have empathy towards a person affected, and also there is an action following that. So the first one is a physiological effect. It is said that when you are talking to the patient, I think for the compassion, when the patient care, you should talk to the patient, and you should be a good listener also. There should be time for you to listen to the patient. The physiological effect has found that the pain perception decreases for the patient. So the pain is felt as less pain because of that emotional effect also, which contributes to the pain also. So maybe it is a pain due to abdominal pain, or pain due to back pain, or maybe a post-anesthetic pain. All this, there had been effects that there is a decrease in the pain as a result of proper approach to the patient. Then psychological effect. Psychological effect means that when this is a neglected disease and there is stigma, so somebody is approaching the patient with a lot of compassion, they will get a confidence that there is somebody with whom you could tell all your problems, and that will be helping for the treatment as well. And psychologically, the depression, it contributes to a decreasing of the depression to a great extent. And studies also have shown that the compassion helps in reducing the anxiety of the patient also. And the third, that's very important, is the patient self-care. Because we may be seeing a patient and you will be talking to them and finding out all the problems with them, and you'll be giving the drugs. That is common for all the disease. Maybe it is a non-communicable disease or infectious disease or anything. You will be giving the drug to the patient, and the patient is leaving the hospital, and out of the hospital in their domestic friend, they have to take the medicines. So suppose they get a confidence on the healthcare provider, and if you approach in a compassionate manner, that feels the patient feels that that he has to take this medicine, and that is very important for him to get better. So that enhances the taking of the medicine, and also try to improve that. And in case of lymphatic filariasis, what I would like to say is that in this morbidity management and disability prevention, one of the most important aspect is the self-care by the patient, because the patient gets the acute fever, and the acute fever is due to a bacterial infection, and for that you have to keep your lymph clean, and that is the hygiene practices. and the hygiene practices is there, then exercise is there, elevation of the limb is there, usage of proper footwear is there. All these things, it is not for one day, it should be there for the rest of their life. So when the patient comes to our hospital, we make them train, we tell them what to do. Then somebody from our staff nurses or somebody in the healthcare provider team will show them or do it on them and show them how it will be done. Then we make them do it. And this has to be continued at home. So there may not be any healthcare provider to help them every day. So that has to be done. So when you have given it with a lot of compassion and feeling the emotions of the patient and feeling the suffering of the patient, and as a method to alleviate the suffering, when you are advocating this, there is every chance that the patient will take it up in a good way. And we have experienced that in our patients, because they, after some time, they'll understand that this is for them. They'll definitely get improved with this, and they will be doing very earnestly the self-care and the hygiene practices. And we have seen, we have recorded, we have found out the drastic difference which will have in them in the daily life, which improves the quality of life of the patient also. The patient not only improving the quality of care, quality of life, this will be perceived as a quality care also. So the compassionate approach has it can make a lot of difference for the patient. That is the physiological or the psychological or the patient's self-care and the quality care. Now, looking from the healthcare provider's point of view, so sorry, before that, I'll just tell you some of the stories or some of the comments which came from this patient. The doctor had told me to wash my legs daily with soap and water before going to bed, to apply the ointment regularly, to keep the legs raised while lying down, and to avoid injury. I do not have any difficulty to carry out these instructions. I am saved now only because I carry out these instructions regularly. Otherwise, my leg would have been worse than this. So the person has taken it as a quality care, and the self-care is being done regularly. I helped a person by washing his legs when I found that he had huge swellings on both legs with ulcers. There were maggots in the ulcers. I washed his legs myself using soap and water and applied the ointment given from here in all the folds of the swelling. The relief of his pain and itching after I did this was remarkable. The next day again, he came asking for some more ointment. Here, what happens is that the person is ready to help another person. So that compassion from the healthcare provider has already been transferred to the patient, and the patient is trying to give it to all of them around his or her area. And what happened was that they formed the self-help groups. And in that self-help groups, they were educating, they were teaching other people how to do it and how to continue it and all that. So in that process, there was a lot of reduction in the stigma also. So the stigma was coming down because of this self-help group system. I have helped others in the disease, and one teacher in the locality had a very large swelling, which was oozing and was foul smelling. I told him that if he kept his legs clean, washing daily with soap and water, and there will not be any problems, and instructed several others regarding this treatment. So that is gone out as some movement, so that everybody has, when the healthcare provider treat or approach a patient with a lot of compassion, that will be reflected back to the healthcare provider as well as to the fellow human beings. Because what is said is that to be aware of the sufferings of the patient, we have to be first of all human beings, and also there should be some humility also. So that becomes a natural thing after some time. So I think I'll be advocating compassion for the management, not only in NTDs, but NTD, they require it because that is a neglected tropical disease. Now, from the point of, healthcare providers, it produces inspiration and motivation. I joined in Alleppey Medical College from a different district, and I thought of going back to after 3 years. But I got involved with this lymphatic filariasis program, and now it is 32 years since I'm continue to do that. And another important thing is that we were doing training for the doctors and nurses of the Kerala hospitals as a part of the SDG program, the Sustainable Development Goal program. And initially, they were not very happy that they have to attend the training, because they said, "What is there in lymphatic filariasis for you teach us for 4 days?" So, but later on, they realized that they are not aware of many things, and they found that they could help the patient in various ways by which they were by simple methods also, which they were not knowing before. So the motivation to continue that, and that was great. And we had patients there whom these trainees were interacting and listening to the patient, their suffering and all that. That also was increasing their compassion as well as the motivation for them. And this could reinforce and strengthen the clinical practice also. And there is a question where there will be a conflict between a technical care and a compassionate care. I don't think so, because that should both, as I have said earlier, both should go hand in hand. There should be a proper technical care should be there, and along with that, there must be the compassionate care also. And difficulty in maintaining compassion in busy practice. Yes, I agree. When you have many number of patients, maybe 50 or 100 patients together in a short time, you have to look. Sometimes you may not be able to take care of every patient. But as far as possible, you can maintain that, and the patient will understand definitely why you are different, quite a little different from the previous days. Then manifestation of compassion. That means that, or the question is how the patients know that you care or you are compassionate. I think everybody will be able to understand when you have compassion and you are expressing it in through your ways. So then just a pat on the shoulder or holding hands. And what I think is that the healthcare providers should be good listeners always. And when the sufferings have been heard of, they will have a lot of relief, and they will have confidence in the healthcare provider. And also, I remember I used to say that when you are sitting in the OPD, there is a half door, and some people or some patients will come and just open the half door. And when they see you, their eyes will be sparkling, and there'll be a smile on the face. I always say that is the best thing which can happen to me as a clinician, as a healthcare provider. So they realize that, and they reciprocate to us at healthcare providers, and also for the other the other people in the locality or other human beings. So the manifestation of compassion would be in different ways, and that even the patient and the healthcare provider will be able to make out. So this should be a part of the clinical practice, and especially in the case of lymphatic filariasis, because they need a lot of care. The patients affected by the lymphatic filariasis need a lot of care, and this care will definitely improve their life. And ultimately, we are doing a study where the patients all of them are trained on this hygiene practices and all that. And we spend a lot of time with them, and whenever they come back, the comfort or their faces tells us that they are more comfortable and there is no problem for them. And compassion could add on to many aliquots of care for them. So that has to be part of it. And I just would like to say about a word about this patient. She has had lymphedema from the age of 15 years, and she had suffered a lot. She was a tailor, but she couldn't do that because of the swelling and all that. And she used to get recurrent episodes of adenolymphangitis and fever and all that. And in that process, once actually she is trying to commit suicide even. And then she was put in that program, and many sessions with her. And later on, she has a lot of confidence, and she started looking after her. And now she's there. She's living with her sister, and this is her sister's daughter. That is the niece, and they have a very big bond because the care is being done by this niece. And her dream is the niece to to be educated, and she gets a job and all that. And she, this lady behaves like just like a normal person, even though the leg is big. So a lot of changes could make, and the change is possible. Changes could be made for them, and I think everybody should be approaching the persons affected with compassion. I stopped this with this quote. I don't know from where it is. If you see someone falling behind, walk beside them. If you see someone being ignored, find a way to include them. Always remind people of their work. One small act could mean the world to them. Thank you.
Thank you so much, Dr. Suma. That was really wonderful, comprehensive analysis and also presentation of the role of compassion in the clinical care that you provide. Thank you for that. I'd like now for us to move to Matthias Duck, who is a pastor and a chaplain at a hospital for Hansen's disease in Paraguay. He's a pastor and a chaplain, and also works now with the leprosy mission in their global advocacy work for persons affected by leprosy. Matthias, it's really wonderful to have you with us. The floor is yours.
Thank you, David. Thank you so much. Just to clarify that I used to work as a chaplain. I no longer work right now as a chaplain, but yeah, that work has informed a lot of who I am and how I try to go forward with my work. It just happened to be that during my first year as a chaplain, I was also diagnosed and treated for leprosy. And that added a whole different perspective to my work and to the way I encountered people. It was during this time that I realized also we had tried to encourage people to talk about their experience of leprosy, and we said we should treat it as any other disease. But once it happened to me, I realized that it wasn't quite as easy as I thought it was. So I realized, even though I had heard from so many people, and I thought I knew what they were going through it myself. And then also my experience was quite different, because I was not going through it in a context of poverty, of lack of nutrition, of stigma and discrimination. But still I was reluctant to share. So I could only imagine how much more difficult it had to be for different people, for people who had so many other adversities going against them. And that's how I got involved. I think also moved by compassion, moved by hearing what people go through, and hoping to make a difference with my story, but also, and especially in my role right now, it is very important for me to listen to people, because every experience is different. People experience it differently. COVID has shown us that the situation has been, for most persons affected by leprosy, I don't know how it is for the other NTDs. I suspect it's similar. It has exacerbated all of their needs and the problems that they were going through anyway. So one of the things that I try to do and that I try to advise others is to listen humbly. I think that when we talk about awareness and empathy, those are probably never boxes that we can check, that we can say, okay, I've got enough awareness. I don't need to be more aware than I am right now. Or I have enough empathy, or I have enough humility. Yeah. In fact, if we do that, we might prove the opposite. This is something that I've been learning for myself, and I've tried to encourage other people to do so, is that we continue to listen and we continue to seek awareness, and we continue to grow our empathy and our humility. And I used to be identified with the hospital. Then I used to be more identified with organizations of persons affected. Now I am still identified with organizations of persons affected, but also identified with an NGO. And sometimes we have, coming from an NGO perspective, when persons affected criticize or ask critical questions, ask tough questions, we might have a tendency to feel attacked, or even I've heard comments saying, why are they not grateful of all the things that are being done for them? And I am trying to learn to, even when the questions are tough and when there's criticism, to listen very humbly and learn, because persons affected, in case of the leprosy mission, persons affected by leprosy, and they are our reason for being as an organization. And we have decided as an organization that we want to center them. So we need to listen to them, and we can learn, because what we might think is the best we can do, if it's not the best for them, and if it's not really improving their lives in all aspects, then we need to improve. Yeah. And so that is, I think, my main point that I would like to communicate today is, listen humbly, and especially when there are tough questions and when there's criticism.
Thank you very much, Matthias. That's a really important reminder for us, for all of us. And I think you point to the need for our compassion to become mature and to be approached with humility rather than a sense of pity or condescension. And really appreciate that message, that reminder, and look forward to picking up on that in our conversation. I'd like now to introduce our final panelist, Girja Shankar, who has a wide range of experience in global health. She's just recently been elected as the vice chair of the NNN. And for those of you who aren't in the NTD field, it's an acronym of acronyms, NTD NGO Network. Girja has been working at the Task Force for Global Health for many years, and then also now with the Christian Blind Mission. And she has a very unique perspective on the role of NGOs, in addition to some of the comments that Matthias has already mentioned. So Dirja, we welcome you to the panel.
Thank you so much, David. And if you can just give me a moment to share my screen with you. Hopefully the only screen you should see is the one big slide.
Looks good.
All right, brilliant. Well, greetings everyone. Again, thank you so much, David, for the invitation. I'm really thrilled to be here and share my reflections on compassion in the context of NTD elimination. Again, boy, what a tough act to follow for wonderful, passionate speakers, but I'll try my best. So I've organized my thoughts, my reflections under 3 themes. First, I'd like to reflect briefly on how I approach the work I do and how I interpret compassion in my global health practice. And then I ask if compassion is measurable. How might organizations practice compassion in timeline and log frame bound projects? Finally, I end with another reflection on the tyranny of words or well-intentioned words. I met these adorable children on a trip to Cabo Delgado, Mozambique in 2015. I was there to observe and learn from an annual mass drug administration campaign for trachoma. I was walking around getting a sense for the village when I ran into them. And as visitors usually tend to do, I showed them my photos from my smartphone, and we all had a good laugh over it. When I reflect on these moments from visiting quote unquote endemic communities, I wonder if the word compassion, and by extension, this notion of suffering, is perhaps limiting in capturing the full lived experiences of people who happen to also be at risk of NTDs, but also go through other life experiences the way that you and I do. And I wonder if the idea of compassion to feel an other being's pain and suffering is perhaps more representative of a biomedical perspective coming from a medical doctor or physician. While I understand and appreciate the intense pain and suffering and stigma caused by many NTDs, as a non-medical public health worker, it is empathy of shared feelings, not just of pain and suffering, but also of joy or the merriment that I see, that I perceive in these children that guides me in my everyday work. So I tend to look at my work from a more human rights lens. Earlier on, I asked if compassion is measurable. From an institutional or organizational perspective, for NGOs that is, it matters that the work we do is measurable, scalable, and replicable. And we're also driven by demands for fiscal prudence, timely delivery of program interventions, and robust epidemiological evidence of the NTD interventions. It might seem as though the exigencies of largely donor-driven public health interventions for NTDs would render any attempt to practice compassion a difficult exercise. The idea of practicing compassion at an individual level makes sense to most of us. And in fact, Uche and Jonathan and Dr. Suma have all talked about the compassion of health workers, the compassion of scientists who are collecting flies, the compassion of community drug distributors. How does the idea of practicing compassion at an organizational level make sense? Or does it make any sense at all? Rather than answering that challenging question, I asked if we might examine some of the work we have already done and ask if the practice of compassion is evident in our intent, our language, and our suggested approaches. Where does compassion manifest in our resources? To that end, I reviewed some of the scholarship produced by the Neglected Tropical Diseases NGO network and its members. I've listed a sampling of the work here. like, for example, the guide on stigma and mental well-being, the guide on working in conflict and humanitarian emergencies. Each of these pieces of work represent the collective experiences of NGOs. Each represents a desire to promote care for the person instead of focusing solely on the disease. This is particularly the case, I would argue, with the guide on stigma and mental well-being, which acknowledges that often people affected by NTDs may not be treated in time or not treated at all and suffer from disabilities and impairments. In acknowledging that NTDs can not only cause pain and suffering, but also stigma, this body of work starts from a place of compassion, or I believe it does. Finally, a reflection on the tyranny of words. How we express what we do signals how we approach our work. Words matter. Is the practice of compassion evident in our language, our everyday jargon? Is every member of every community affected by NTDs a patient, or perhaps an active participant in a public health program? As a non-medical public health practitioner, again, I'm uncomfortable using the word patient. And it might be entirely applicable to Dr. Suma, who is in fact a service provider, a frontline service provider. How about the word beneficiary? Is that signaling compassion, or is it signaling pity and charity? A few other words that we employ, like capacity building. I use that word all the time. But whose capacities are we building, and for how long? A few other, and words like intervention. I've used this word already a couple of times in this short presentation. How can a practice grounded in compassion be an intervention? Maybe it can, but these are some words that jump at me. And finally, human interest story. Isn't every story a human interest story? And so with those reflections, again, I thank you so much for your attention. Thank you to Wendy McAfee and to the NNN Executive Committee for their feedback. And thank you to David, Ashley, and Heather for their invitation to share my reflections with you.
Thank you so much, Girja. That was really wonderful and nicely wraps up our panel with some provocative questions as well as some really keen insights. At this point, I'd like to turn it over to Shams for moderating the panel discussion. Shams?
Great, thank you so much, David. What a wonderful set of perspectives and thoughts. If I can invite everybody to perhaps put their cameras on, the panelists, and if we could, yes, that's wonderful. Well, I've certainly learned a huge amount just by listening to the wisdom of the colleagues that have shared their thoughts. And we've had expertise from different parts of the world, different continents, different deep dives into specific neglected tropical diseases. So I'm going to ask each of you a couple of questions that jumps out immediately. But I did want to start with a question that's emerged from those that are listening. So the first question that has emerged, which is I think an excellent question, is compassion contagious? So I think it cuts to the chase really in terms of the essence of this global health compassion rounds. And if I may just go in sequence with starting with Uche and then turning to Suma. Uche.
Thank you, Sham. Yes, in some instances, circumstances, you can say that compassion is contagious. What comes to my mind is the initial hesitancy of drug distributors, some that are selected by communities to serve them. And so they hesitate. But then when they begin to see their colleagues doing that and going from house to house or central place distributing NTD drugs, you find a number of them coming back to their community leaders, volunteering to join this group of distributors of medicines serving their communities. So that's, to me, that's one example of compassion being contagious. It's also contagious if you look at the demand for incentives. We have experiences from all NTD programs that community people, distributors of medicines, in certain instances, they demand cash incentive. And they are right to do that, but we cannot pay them cash incentive, otherwise the programs will collapse. So the NTD programs now depend on those who are volunteer CDDs. Now, there are reports always where people who were hesitant at the initial stage or would not join because they had no cash monetary incentives would then come back later and join the crusade of volunteer community-directed distributors of medicines. But there are instances where I would also say, even at a higher level, that it is contagious. From my experience in APOC, working with over 20 donor countries and 14 international development organizations for almost 20 years, I realized that at the initial stage, when the donors come to meeting, because they are represented by their scientific officers, it's not all the scientific officers that really appreciate the issue of listening to communities, building trust with communities, showing that emotional response to people who have pain. But over time, you find that they begin to buy into it and become even crusaders, that when they review reports, they're asking you, well, what did the community people say? They want to hear from the community. They begin to buy into it. What Matthias said earlier becomes extremely crucial to them, that they want to hear, they want to feel the pain, they want to be part of the pain of the people. And so I very much liked the presentations of my colleagues, all of them. And I think that compassion can be contagious in some instances. Thank you.
Thank you, Uche. Clear affirmation on that and a beautiful description. And the way that you highlight compassion is a thread that runs through everything is quite a snippet that I think we'll all take away. Suma, if I can turn to you for your thoughts on whether compassion is contagious.
Thanks, Shams. Yes, definitely. Compassion is contagious, and I feel that it should be and it must be. Even if there is a person who thinks that this is not very important, you should not be listening to the patient, or you should not be spending a lot of time with them and not very much interested. Suppose the person who goes on listening to that, and after some time, I'm sure that that person will also have will start doing that or start following that, and that is several occasions that have happened also. And because that's a beautiful feeling, and that's a beautiful thing which has to be passed on, so which will be benefiting the patient or the persons affected a lot. So that we are, as healthcare, from the part of the healthcare providers also, we have to, or we must be doing that, and the compassionate care should be part of everything. Thank you.
Very clear, Suma. And in fact, you also mentioned the interesting conflict between technical care and compassionate care. So there's probably a interesting injection point there for contagion. Matthias, I think in the chat, lots of people have been commenting on your call for listening humbly. But can you expand in terms of the of compassion? Over to you, Matthias.
Yes, well, I don't know if there's any evidence on this. Perhaps David can enlighten us on that one. But I think because in the end, compassion is like an attitude. So sometimes you say that negativity is contagious or positivity is contagious. We can certainly say that with leprosy and even we look at other situations in life is that sometimes hate and prejudice can be contagious. So I think compassion is and can be contagious. We have a lot of rival attitudes that we have to deal with. But I think all of us, when we work in a context, and I've said this to doctors, you know, the way you encounter a patient that is being stigmatized by the community, you can make a difference. Perhaps it will not be automatic, but you can make a difference in which the community sees how you encounter that patient, and the community starts to see that person in a different way. So I think yes.
Thank you, Mateus. Very, very clear. Girja, turning to you for the same question. You've brought out many dimensions in your intervention. So over to you.
Thank you, Shams. I actually have two responses. So the first one is, is in the short term, yes. In the long term, I don't know. Because right now, let's take the example of the earthquake in Haiti that just happened, a few months ago. We all want to do something. We want to write a check. We want to do something, and perhaps we also want to be seen as doing something. In the long term, is that sustainable, right? Is that ability to sort of empathize with another person's suffering over the long run sustainable? I don't know. But on the contrary, I looked at this NTD community right here. Think about how small this community was just a decade ago, 2009, 2018, 2011, and think about how much it's grown, and think about the phenomenal advances we have made. So clearly, looking at the evidence that's presented in front of me, I have to say that yes, indeed, compassion is contagious.
Thank you, Girja. Very clear. Jonathan, as you listen to the panelists and reflecting on this question, your thoughts?
Thanks, Shams. I was thinking about, I felt I had to do some self-reflection because I used the word capacity building, and I thought, well, Girja just told me that wasn't appropriate. But so what we mean by that, and I'm going to tie this back to the, is it contagious? What we mean is teaching a skill, out of compassion. We want more people to learn who can then apply that learning in a way of compassion to help others. Suma, I'm surprised she didn't bring it up in her answer, but the example that she presented in her presentation, she spends a lot of time starting these self-help groups. Like she has to teach new skills to people who are affected with lymphedema. And then we have the example that she had quotes of someone who is affected by lymphedema and LF, teaching another person, seeing someone in the community who could use those skills and use that help. And I think that was an act of compassion. In some of the, what I would say, capacity building that Suma does, she gives so much in running workshops, teaching program managers in LF endemic countries, or program managers who may have come from other aspects of primary health care or public health and just coming into LF. And I've witnessed some people coming into that workshop who would seem maybe not the easiest personalities. Kind of, if you saw them, you would think, where is the compassion in this person? But by the end of it, through Suma incorporating compassion in the training and having this person involved in leading a program to then apply this and then see them go and wash someone's leg who's affected. It's really, it was really rewarding to see the change and the contagion of compassion.
Jonathan, fantastic. Thank you. I know time is short. I'll turn to David for his closing remarks at the end. I'm going to just dig it just a little bit deeper now with each of the panelists. So there's an excellent question coming through related to the word neglected in neglected tropical diseases, and whether that actually elicits pity rather than compassion. So just keeping in mind, and this is also linked very much to perhaps the tyranny of words that Girja was highlighting earlier on. But if keeping that in mind, I just want to probe just a little bit on a couple of points that each of you have made in your intervention. So Uche, I wonder, you told a remarkable story of Agnes, right? Do you want to give us your reflections on how she felt? Because you know about that as a personal story, right? How did Agnes feel about her role in catalyzing global change? And then while you think about that, Suma, I was just going to come back to you in terms of your emphasis on patient care and clinical management. Do you feel that the word neglected has a meaning beyond what it should have in terms of this point that the colleague has asked? So Uche, turning to you first, and then Suma, and then of course then turning to Matthias, particularly on this wording issue, as somebody who has been affected by leprosy. Uche, your thoughts, and then turning to Suma.
Thank you very much, Sham. I want we all to put on the heart, remove your hearts and put on the heart of Agnes, a 19-year-old girl, pregnant, was separated or sent away by her husband, filled with lesions, itching lesions, cannot sleep. So I wonder how you feel being in that situation. Neglected? I would think so. And so, but Agnes rose from that after receiving ivermectin from the Carter Center program, which covered the area where she lives, and for a number of years. But you can see that the neglect which she felt at the initial stage was removed when her lesions now disappeared gradually. And Agnes, with time, became a community-directed distributor, which she is till today. So for the more than 10 years now, Agnes has been a CDD, distributing the same ivermectin, moving from that initial pain of feeling neglected. And she has also rejoined her husband. Now she has 4 children. In 1990, Agnes was pregnant with her first child. So the word neglect is good, but we want them to move from that sphere of feeling neglected to being human beings that are appreciated in their communities. Thank you.
Very clear, Uche, and succinctly put. Suma, turning to you for some thoughts.
Sorry about that. Thank you, Sham. Then regarding the clinical management and the neglect, actually, there was a stage where these people affected with that were neglected so much, because I'm working in a hospital which is in an endemic area where the prevalence used to be very high. Now things are changing. So a person with lymphedema was never treated with the same dignity as other people, because it is the leg which may be foul smelling or maybe oozing, or looking at the leg itself, the grotesque appearance and all that makes people move away. So there, when I joined here, that is years back, there used to be a ward where all the legs are being kept. So it is being said that there is a ward for the legs. So that was the neglect which the people experienced. And not only that, because they know that they may be, when the patient comes to the hospital, they may be given some analgesics or antibiotics and all that, and nothing more than that. So because of that, many of them never wanted to go to the hospital, because they knew that they will be kept at a corner of the ward or somewhere and will not be taken care of. But things have changed a lot now. And another factor, I think, is that those days, there was not much knowledge about the pathogenesis, the disease, about the disease, what you can do for the patient. But that knowledge is now widespread, and many people know that we can, by simple methods of hygiene and all those things, we can give a lot of relief for the patient, and we can help them a lot. So that is moving on. I think I always tell Jonathan also that we should make a movement like the spread of the knowledge, because the knowledge sharing, that is very, very important. Even now, there are areas where the healthcare providers are not aware of this management of lymphedema management and other aspects. I'm sure the people who are working in the program management, or those taking care or special care on this tropical diseases, they will be knowing, but the general primary care physicians will be taking part in that. Really, they may not be knowing it. So there used to be neglect, because people think that, oh, we don't have much to give to them, so let it just see it like that. So there was neglect, and that is changing. I think I'm happy that there is a lot of change happening nowadays. Yeah, thank you.
Great, thank you so much. Matthias, I know that people will want to hear from you. Words count. What's your thought on the word neglected and how it links up with this compassionate discussion?
Well, I think David made some efforts when he introduced us to mention, I think at least 2 times, that he did not talk about NTDs so much as did he talk about diseases that neglect people. Or and I wrote it down here, MPDs, neglected persons diseases. We've had this discussion already in the NNN, in the network of NGOs that work with these diseases. And I think there is something to it. I think we need to continue to think about that. Why do these diseases, we know specifically about leprosy, that leprosy was, there are former leprosaria all over Europe. So, and how did it change? It changed before we found out even what the bacteria is. It changed because people got better living conditions. So there's a lot of things that we have to think about, yeah. If we really want better, if we really want to fight these diseases, then we have to work structurally at some of the things that are going on in certain parts of the world more than in others. If we talk about compassion and pity, we've had this conversation with David and with a few others. I think language sometimes matters, and for some of us, language, English is not our first or our main language. I know that in Spanish, those terms sometimes get mixed up. And I also think that we should sometimes examine ourselves, because sometimes we come from a position of, I don't know if superiority, but there is a power imbalance. There is a knowledge imbalance, or there is prestige imbalance, or we come with an organization, we have the power to decide things. And I think we should always examine ourselves. Am I seeing this person as an equal, even though there is, from all what people see and how people see me and how people see this person, there is a big imbalance. So I think, and I think that will determine then if it's pity or if it's compassion that is within us and that we're also showing and projecting.
Great points, Matthias, and certainly sparking some thinking that we all need to take forward. Girja, over to you.
Thank you, Shams. I'm with Dr. Suma here. I think the term served a very important purpose. I think it elevated awareness around the need to address diseases that were affecting millions of people that weren't necessarily getting the attention they deserved. So absolutely, it served a purpose. But I think today is also, it's also the right time to ask these questions, because like the commenter had said, the idea when you say tropical diseases, it conjures up certain images, it conjures up certain notions. And it sort of, harkens back to Matthias's point about asymmetries, power asymmetries. It's tropical, neglect, bad, temperate, good. So I think it's a good question to ask. Let me put it that way.
Thank you, Uche. I know time is very short, but before handing back to David to close us out, some final thoughts from you, Jonathan.
On the neglected, coming from the Department of Neglected Tropical Diseases. And the word tropical too, I was thinking, PAHO decided to change the department neglected infectious diseases. And I think having the neglected there, it really did, it served purpose to increase the advocacy. And we all should be, at least I'm grateful for that, because it brought more resources into the work that needs to be done. And then at the same time, neglected persons' diseases really cuts to the point of the person-centered approach, right? So it's the person affected that we have to bring attention to. We have to listen to, as Matthias said. And are our aims and intentions really meeting the needs, or is that what a person needs? And I think it calls it, we need to reflect on that. But I think NTDs is it's okay to continue using this. But I think it is nice to have this discussion around what is the focus and what does it portray. So,
thank you, Jonathan. Thank you very much. So time is extremely short now, so we might even get shut down at any moment in terms of the webinar architecture. So one of the things that I just wanted to end on before giving it to David to close is the point, Jonathan, you're making about people-centeredness. So it's a fundamental point that WHO has been emphasizing in terms of people-centered health services, people-centered health systems, and of course the linkages with creating quality health services is evident and clear. We won't have the chance to go into depth in that, but that's also something that we could perhaps spark as a discussion from this point. People-centered health services is a core component of quality health services. But over to you, David, to close us out.
Thank you very much. And I would just, that's a nice segue to say that the new NTD roadmap that Dr. Molichella pioneered and developed and was done with great collaboration of all of the partners really does take that person-centered care as a central pillar. And so it really, the whole NTD movement is definitely on that trajectory of person-centered care already, thanks to Dr. Molichella's leadership. I just want to thank all of the presenters. I want to thank all of the listeners and audience who've stayed with us for a few minutes over time and for just such a fascinating, rich conversation. It's not possible to summarize this, so I won't even try. But I want to say how grateful I am for this opportunity to lift up the theme of compassion in NTDs. Really does seem like the engine, the fuel that drives all of this activity, this amazing body of work, this community of practice that is making such a difference in the world. That speaks to the power of compassion, and we heard several testimonies to the power of compassion in individual lives in programs. And I just want to note that we don't often think of compassion and power in the same sentence, but I think we've borne witness to the power of compassion to alleviate suffering and to move us as human beings. Part of our reason for being together is to challenge each other. Matthias has reminded us that we don't just get compassion once and then we got it. This is a continual process of exploration, of having humility to question our own words, our assumptions, and to exchange ideas with each other so that as a community we can become even more compassionate and more effective. And I really want to thank particularly the colleagues who have raised questions for us to consider today. We will carry those questions forward, and those questions really help us perfect and mature our compassion, both as individuals and as organizations, and hopefully as a field. So I just want to close by expressing my deep gratitude to each of you participants. It's really a joy for me, since I consider you all friends, to have you all in one virtual meeting. And I so appreciate your wisdom and your contributions. It's been a wonderful session. We will develop a report. The recording will be available on the website, and you'll be receiving the report in advance to make sure we've captured your remarks in the way that you would like. So thank you very much, everyone. And we will be back in next quarter for another session of the Global Health Compassion Rounds. Thank you so much.